Well, I think I'll go ahead and get started. I want to welcome everyone to the DMICE Research Conference. And we're going to be presenting today an integrated approach to breast cancer risk assessment using MammoScreen and EPIC in primary care. And you're going to hear from a panel of investigators on this project. Next slide. This work is funded by an ARC R01, and we have no relevant financial relationships with commercial interests to disclose. Next slide. As you can see, we are a multidisciplinary team that includes clinicians, informaticians, EPIC for research members, an expert from UCLA on breast cancer risk assessment, a genetic counselor, and importantly, we have 5 patient advisors between the ages of 40 and 74. Next slide. I thought I would begin with just a little tiny overview of what a patient decision aid is, because MammoScreen includes not only a risk assessment, but also a decision aid. And these are tools that help patients become involved in decision-making by providing information about options and outcomes and helping patients clarify their values around those. But they are designed to promote conversation with a health practitioner, not to replace a healthcare practitioner. Next slide. Decision aids help with shared decision-making by providing information on options, importantly, establishing a common language so the clinician doesn't spend 15 minutes just going over the terminology and that sort of thing. It's also a way to give patients a safe environment to set priorities for the decision, and it provides a structured guidance for shared discussion. Next slide. So there's been a Cochrane review that's been conducted probably over the last 15 to 20 years. And the most recent review in 2017, 105 RCTs revealed that patients using decision aids, when compared to usual care, reported greater knowledge, felt more informed, felt more clear about their priorities for the decision. Also, fewer people were passive in decision making and fewer remained undecided. Next slide. And if you're interested in whether there's a decision aid on a topic that you want to explore, there's an inventory of decision aids that's kept by the Ottawa Hospital Research Group. So you can go to this site and look to see if your topic is already in a decision aid that you might want to consider reaching out to the developers. Okay, next slide. So MammoScreen was developed using the International Patient Decision Aid Standards. Sorry, just a second. My barking dog here. And the goal of the IPDAS collaboration is to establish an internationally approved set of criteria to determine the quality of patient decision aids. And Lindsay, if you'll just start flipping through there's 4. Is there enough detail to help you make a decision? Is it unbiased and understandable? Next one. Does it help you clarify your values? And finally, is there structured guidance for the conversation later? Let's go on to the next slide. So the MammoScreen tool was developed in partnership with patients and primary care clinicians, and it was designed to support the USPSTF breast cancer screening and prevention recommendations, to identify patients who might benefit from genetic counseling, to educate average risk patients about breast cancer screening and current recommendations, and to facilitate that shared discussion. And finally, and this is what we're really focusing on in this new work, improve accuracy and completeness of patient medical and family history related to breast cancer risk in EPIC. Next slide. Just a quick overview. We started this work in 2012 with women 40 to 49. We then expanded the tool to address the needs of women 40 to 74. And you might be wondering, why do we need a decision tool for 50 to 74 when screening's recommended? But what this tool helps the patient and clinician know is whether the person should come every year or maybe every 2 years. In 2020, we received an R01 to begin integrating MammoScreen with EPIC. And we actually launched recruitment with this new tool, integrated tool, in 2022 in OHSU internal medicine clinic. Okay, next slide. Just to give you an idea of what kinds of questions the patients answer around breast cancer, these come from a validated tool, and it asks questions about personal history and family history. And just even since this tool has been created, we've now also added an unsure category that's not shown here in this slide. But if the patient doesn't know, for example, about BRCA family, you know, if a family member's had it, they can check unsure. Okay, next slide. The patient gets a report. In this particular instance, after answering the questions, the patient learns, this particular patient has a previous history of breast or ovarian cancer, so the actual decision aid isn't appropriate for this person, but it does help them understand any next steps. What we also found out is that for women at increased risk, MammoScreen helped identify an additional 10% of patients. And there was also discrepancy between the risk information in MammoScreen and EPIC alone. Some of that just being the currency of the information. The patient may have had a new family member who was diagnosed with breast cancer, and it's just simply not in EPIC yet. Next slide. So for the patients who are average risk, they go on to use the decision aid. And this is a graphic that we created that helps women understand that some breast cancer grows very aggressively, some grows quite slowly. And as you can see, we've used graphics, we write things in plain language, we test this with our patient advisors, and we often have quite a bit of pilot testing with clinicians and patients before we roll out a decision aid. Let's go to the next slide. In this graphic, we're trying to help the patient understand the yield of screening, but we don't use terms like yield of screening. And we customize this particular graphic based on the age of the woman. So if I was in my 40s, I wish I was, but I'm not. If 1,000 women in their 40s had a mammogram today, 125 would receive that dreaded phone call that more tests are needed. 2 cancers would be found and 2 precancers would be found, but 121 would not have cancer. And if you click the button there, Lindsay, it'll highlight that. If for the normal results, 874 of the 875 would be told they had normal results, but there would actually be 1 cancer missed. Let's go to the next slide. So then we have them set some priorities, and you can imagine that we initially had quite a long list of benefits and quite a long list of harms, but through work with patients and clinicians, we narrowed that list down. So we asked them to pick the one benefit that is important to them. In this case, it's peace of mind, having a mammogram that shows no cancer versus catching cancer early. We also asked them to identify the harm they most want to avoid. In this case, we're showing extra tests and worry, and no improvement or length of life. Notice we don't use terms like overdiagnosis or false positive, because those are very difficult terms for our audience to understand. And then we ask them to pick the one benefit or harm that's most important. Let's go to the next slide. So in 2020, we published the most recent data collection that we did at the Internal Medicine Clinic, and we collected data on feasibility, uptake, and some clinical data. Let's go to the next slide. So what we found is it was feasible to integrate MammoScreen into the practices. In terms of uptake, we sent messages out by MyChart. 76% of the patients opened their chart, and 37% of those patients used MammoScreen. So they clicked the link within to get to MammoScreen. Most people spent about 6 minutes using MammoScreen, and the clinical team reported positive experiences. And what we found is that it provided more timely and complete breast cancer risk information than was currently stored in EPIC. Let's go to the next slide. But we also learned there were some challenges. In order to put information back into EPIC, we had to manually put this information back in, and that it could be error prone. It was labor intensive. Also, the system required us to send manual MyChart messages that had embedded in them and encrypted the MRN so that we could match the MammoScreen report back to the correct patient. And then finally, the patients had to answer questions that might already be in the medical chart. So with all of this in mind, we designed our new study. Go to the next slide. And that is to integrate the MammoScreen tool with EPIC, to evaluate clinician use of MammoScreen, and to evaluate the patient uptake of MammoScreen. And next slide. And with that, I will hand off to Dr. Nelson to speak about breast cancer screening and prevention clinical recommendations and risk assessment.
Thank you so much. Good afternoon or morning. We're kind of on the cusp of that. I'm going to spend the next few minutes describing the breast cancer screening and prevention clinical recommendations and risk assessment that is embedded in MammoScreen. As Dr. Eden indicated, the initial motivation for developing a tool was to help clinicians navigate the sometimes confusing and conflicting recommendations regarding 3 breast cancer screening and prevention recommendations for primary care. These include mammography screening for average risk women. There's some loaded words in here we're going to go through here in a minute. The second one on risk assessment for genetic counseling and genetic testing for BRCA1/2 related cancer. So these are subset of women who have genetic predisposition for cancer. And then the use of medications to reduce the risk of breast cancer. So I'll just highlight that these recommendations have all been endorsed by groups that are including HRSA, the Women's Preventive Services Initiative, which I've been working with for many years, and the U.S. Preventive Services Task Force, which we've also been working with for several years, have established and accepted these guidelines as a standard of care and covered under the preventive service mandates of the Affordable Care Act. So they are provided without copay or deductible charges. So these are supposed to happen. So go to the next slide. I'm not going to go through all of this, but clinicians in the room or anyone who's been eligible for these types of recommendations will appreciate how messy this gets the deeper we go. Who is average risk? That is a million-dollar question. We're trying to help determine through an easy tool. That's why it's taken us so many years and a lot of effort. Average risk women are the target population for mammography screening for the recommendations that I just mentioned, but also for the MammoScreen tool. So the recommendations that are covered under the ACA come from HRSA through the IOM and the WPSI. We worked on these for many years, but all women can initiate mammography screening no earlier than age 40. We're talking about routine average risk women, and no later than 50. Screen every 2 years and as frequently as every year based on clinical considerations. Continue through at least age 74, but age alone should not be the basis to discontinue screening. And a shared decision-making process involving the woman and her healthcare clinician should be used for decisions about when to initiate screening, how often to screen, and when to stop. So that's quite a few things to go through. The U.S. Preventive Services Task Force issued C, B, and I recommendations, which some of you may be familiar with, meaning individualized screening. For a C, everyone should be screened. For a B, and no evidence for an I. So this gets a little dicey. If we had another hour to talk about this, we would have other organizations have different screening recommendations. So this is rather messy. If you go to the next slide, the other recommendations involve the breast cancer risk assessment for genetic mutations. So the recommendation is to screen all women with a risk assessment tool to identify patients with family histories associated with these mutations. And those that screen positive with a tool or a set of questions or some kind of instrument then would receive genetic counseling, which is a whole nother encounter involving at least an hour and software and kindreds, and it's a whole nother referral. If indicated after that, then they would undergo genetic testing. The third recommendation involves identifying who's at increased for breast cancer and who might benefit from medications that actually reduce the risk of breast cancer by 50%. Tamoxifen, raloxifene, aromatase inhibitors. So again, here we're talking about risks, risk assessments, shared decision-making. When is that going to happen? So let's take on the next slide. For the first question, who's at increased risk for breast cancer? So let's take a look. What would help us sort that out? Well, we unfortunately found, after reviewing the predicted performance of 18 risk assess instruments involved in 25 studies with over 5 million women enrolled, including the so-called popular Gale model, that they aren't helpful. They are not accurate in estimating risk. Their discriminatory accuracy range from 0.55 to 0.65 for those of you in that field, that is slightly better than a coin toss as to who actually will get breast cancer. So that's not too helpful. So what are we going to do? We've gotten a lot of pressure to implement the Gale model or other models into MammoScreen, but we've been pushing back. If we go to the next slide, we'll see what's in the Gale model listed in the first column: age of menarche, a bunch of other things. All the other permutations of the models kind of grow from there. There are all kinds of other things added. In reality, they don't all, the more you have, more factors in there, it doesn't perform better. The most dominant factor in all these models is age. So we took a different approach with MammoScreen, very intentionally. If we go to the next slide, MammoScreen identifies individual factors that we call red flags. These are clearly high risk factors. So if those of you who've done the demo, the first few questions are about, do you have a symptom now? Do you have a breast symptom? Lump, discharge, skin change? We want to sort that out before you go too far into this. Have you had radiation exposure at a high level before age 30? That's a very small slice of the population. Maybe someone who had Hodgkin lymphoma treatment. That increases your risk. That's a red flag. Do you have a mutation or a family member? We need to sort that out. Have you had previous cancer, breast, ovarian particularly? That could be a problem. Then we move on to the breast biopsy question. There have been a lot of people who have had biopsies. Most of those aren't show no cancer, but a chunk of those show a high-risk lesion. They're in a different category. They need to be followed more closely. And sadly, a lot of people don't know what their biopsy was. So we need to sort that out. We can't really label them as average risk. We sort out who's at high risk. So this is the first part of MammoScreen. It helps sort out these kinds of risk factors and who might go on to other things before even considering routine mammography. To go to the next slide, we go, well, who is eligible for genetic counseling? Remember, we're trying to help sort through that so that clinicians can satisfy that practice recommendation to refer on the individuals who may need counseling. It's not a large population that has these mutations, but it's enough. Up to 7% of women with breast cancer and 10 to 15% of women with ovarian cancer are carriers of inherited pathogenic mutations. They pass these on through relatives, and they may appear kind of out of the blue for some families. Some families have, sadly, a fairly trackable record of cancer, but it's important to know who's carrier, and they have things they can do to reduce their risk, including some pretty drastic things like mastectomies. But they should know their risks. So a carrier of either of these mutations has an increased risk for cancer. It doesn't mean they're going to get cancer. So we consider them risk factors, not a 100% risk carrier that it's going to happen. So we need to sort that out. So if we go to the next slide, we see that we looked at all the tools that you use to triage women to see who's has a mutation. And actually, these are accurate. They have very precise questions about family histories that are quite linked to some kind of genetic tendency. We looked at 8 risk instruments in 14 studies with a large number of women, and the performance characteristics were more in the clinical feasibility range. And so we thought those were helpful. So if we go to the next slide, we opted we reviewed all these from MammoScreen and selected one that was developed by the CDC and validated in large populations of American women. So hopefully reflecting as best we can that population. As you can see, this is so simple. It can be done as a paper pencil test in a low-tech environment, but MammoScreen and others are implementing these more in electronic systems. But based on a series of simple questions, the person gets points. If you have 2 points or more, you need a referral to genetic counseling, where they can actually spend a lot of time getting more precise information and actually create risk estimates that are going to be useful in decision making. So this is a triage. This is not a definitive family history assessment, but it's what the task force is asking people to do based on the science that this is helpful. If we go to the next slide, see how this fits in. Okay, we got through those first risk questions. remember the biopsy and all those other things. Now we move on. As you may have seen from the tool, a point is gained for anyone with Ashkenazi Jewish heritage, since there is a cluster of genes and mutations that can increase risk for cancer. So that's an important population in this US population that we need to keep an eye on and evaluate. We look at family histories, and unfortunately the mutations can fly under the radar for a while, so you may not know. But generally it expresses itself, and an expressed gene is an important gene. So it's important to know histories, and we asked a series of questions that Dr. Eden showed a few of them a little more up close earlier. So once they get through this, we have a better idea of who may be at higher risk. We can go on to the next slide. That's, I think, my last one. So now we go back to our first question. Who's at average risk? Well, it's a process of elimination in the MammoScreen tool. And probably we thought the best way to really sort this out, average risk is not having characteristics associated with high risk. That was previous diagnosis of ovarian cancer, high-risk breast lesion, clinical signs or symptoms of breast cancer, carriers of those mutations or other familial syndromes or other syndromes besides BRCA. Those will be picked up probably in the system too. And once they get to genetic counseling, they can really sketch out those family histories. And then that high dose radiation. So we now know who could move on to the mammography screening piece of the MammoScreen tool. And hopefully these individuals will get their high risks addressed. So I'll stop there. I think that's the last slide I have.
Hi, excuse me. Hi, Katie Bensching. Can you hear me? Can you guys hear me? Yes, no?
Yep.
Yes, we can.
Oh, okay, great. Hi, so my name is Katie Bensching. I'm a primary care clinician, doc, it's a clinician educator, a generalist by training and continuing, but also with a focus on women's health within the primary care environment from when I started my career. So this is a copy of some of our team who happened to be in the clinic during the pandemic and the front desk of our clinic. I am going to talk about the clinical workflow related to MammoScreen and some of the details there. I do want to thank some individuals on our clinic team as well as the whole group. So in the pilot study, I had two partners, Dr. Haney and Hassan, who helped with the pilot, and we've had Abby Chesmet, who's on this call as a panel coordinator with medical assistant training, who's been our key on the ground person. And as we've moved toward the R01, eventually there'll be about 75 faculty and residents involved in the study, as well as about 8 nurses helping us. Next slide. So this is the MammoScreen workflow. This is specific to our clinic and Epic. MammoScreen is adaptable to essentially any EMR or clinic workflow. And we are tracking the decisions and issues that have come up about the clinic workflow to help others who may be implementing in different settings think through things, but this can be adapted very differently in different settings. I want to note that there's 6 steps and that there are 5 steps before even anything comes to the clinician. So one of our goals was to make sure this was really, really high yield and low burden to the very busy primary care docs on the ground. Next slide. The first step is a MyChart invitation to the patient. Now, and we've actually reworded this invitation several times to increase our yield of responses. You all probably already know this, but it is very common for research studies to use MyChart invitations as one of their primary sources for recruitment. It is asynchronous and therefore convenient for patients. Some patients will open MammoScreen and come back to it after they've been able to talk to relatives. So we think we're getting better information by doing it this way. And it doesn't take up the precious time of a visit. But of course, anyone who doesn't have MyChart would not have access to this, and folks who aren't as digitally literate or not as facile with using MyChart or even other digital applications might not have access to it. Next slide. So risk assessment's the next step. I think that obviously Heidi went through this in a wonderful detail and explained the reasoning and the process. But essentially we'll find out, but the unique part to this study is that, and this application of MammoScreen, is that we can pull information to and from Epic and MammoScreen to coordinate the information. So the patient actually reconciles health history that's already in Epic and doesn't have to repeat it. And we can make sure that, and if there's inaccurate information in Epic, the patient can outline that. Next. This is the patient report. So a patient receives a personalized report. The information here matches in content, what's sent in the clinician report, and is saved to the patient records in a plain text version as well. Let's see. This allows us, as Karen said, us to not have to do manual entry into Epic and avoid errors. It allows us to do some standardized automatic workflow of the outcomes of the reported issues. So for example, if symptoms are reported, we can automatically send to the nurse. If the patient is not average risk, it can go to our panel coordinator. We'll go through that. And we, in developing this, we used our clinic workflow, our standard clinic workflow for each action as much as possible. Next slide. This is the clinician summary. It's automatically saved to this chart. It's easy to find via just a simple search in Epic. There's a report that is sent to the triage nurse only if there's symptoms, and we developed this with input from our clinicians over serial discussions to make it most useful for them to be able to find what they need easily. And again, it matches what is in the clinician record. Next slide. So this is a care coordinator note. So Abby Chismet is our phenomenal care coordinator, and she receives these reports and creates a note when appropriate. So this again has been iterated with Abby making changes and the clinicians giving input. This is automated. So can you just start the automation, Lindsay? I think. So the care coordinator next. It'll have the date where the data came in, so it's clear when the patient filled out the MammoScreen. Next. It'd be if patient has new or changed information that's highlighted at the top in red, so it's easy to find. Next. So you can easily see, oh boy, does this patient have an appointment coming up? I just need to remind myself to talk to him about it, versus, oh, I need to take some action to have the patient schedule an appointment. Next. Dates and locations of the mammograms and breast biopsies that are able to be found and pulled in, and those are the ones in Epic and Care Everywhere, are pulled in for ease. Next. And this is the full clinician summary report. Next slide. And then we outline various actions that can be taken based upon the patient's risk and their reports. So for example, if someone's average risk without any new information, that no message goes to the primary care doc, everything is filed, and the summary is expected to be potentially reviewed at the next patient visit to facilitate shared decision-making if that needs to be done. Versus if someone has new symptoms, the message is sent to our triage nurses, as with any, whether someone called in or sent a MyChart message saying they have a breast symptom, would be treated the same way. And then the nurse takes care of that before it comes to a clinician. The three middle situations are where the care coordinator would send a message with the information, and the primary care doc would need to make some decision about what to do. For example, if they thought they had a significant family history that they screened positive for risk for BRCA or BRCA, they would probably have them come in to discuss a referral to genetic counseling. Next slide. The other thing that happens automatically is a problem list entry to reconcile is posted in Epic, and it's called at above average risk for breast cancer. And this can't be automatically put in, it has to be reconciled by a provider in Epic. But but it's very simple to do so. If you see it, you can just click that problem list entry and it will automatically pull in the MammoScreen report, so it's easy to find. Next slide. And this is a little bit another way of looking at our notification process. If a patient has no breast symptoms, then the nurses are not all involved, only our care coordinator. But if there are breast symptoms, the triage nurse is also involved. If the patient is average risk, no automatic notification happens. And so the idea is only to send to the clinician what they need to see with as much information as possible from the team and the background of MammoScreen before it gets to them. Next slide. So we have lots of lessons learned. Obviously, MyChart invitations to participate are successful, but will not lead to engagement with all patients, and we've been working hard on that. We've had input from stakeholders that has been invaluable and continues to be, even since we've, every time we redo this presentation, there's something else to add. The patients requested the option of unsure. The clinicians requested risk-based cancer screening and prevention recommendations, which I'll show you next. The genetic counselors requested that patients being referred to consultations be noted that they're going to look at their genetic risk, not just for BRCA, but other things. The nurses requested that we clarify that whether breast symptoms were new or old, or whether they were evaluated or not. We are customizing the patient invite to include the PCP name. And clinicians request a variety of training materials, including a short demo video for reference. Next slide. Were you going to show the video, Lindsay?
Yeah, I can go ahead and show the video.
Okay.
So this is from the training for the clinicians. It just kind of briefly goes through the how a clinician might process a MammoScreen report. One of the requests that the clinicians have made is that it needed to be, 2 to 3 minutes long. So I actually used an AI voice generator called 11 Labs for it to create a clone of my voice, and then I typed out a script, so it really streamlined the work. So I'll go ahead and play now. Maybe. Let's see.
Hello, my name is Lindsay Watson. I'm the project manager for the MammoScreen study at OHSU. In this short demonstration video, I'll walk through an example of how MammoScreen fits into the PCP's overall workflow. You can find more information about MammoScreen in the IMC Wiki, on Teams under Epic Tips, or feel free to reach out to me over email at watsolyn@ohsu.edu, or send Dr. Bensching a message on Teams, InBasket, or Outlook. For this demo, I'll walk through an example case in the EPIC test environment using fake patient data. We'll start at the point in the clinic workflow where the PCP receives a notification from Abby Chesamet, the study care coordinator, who has reviewed the patient's chart for additional pertinent information such as date of last mammogram and highlights the new patient reported information before routing to the patient's PCP as a patient call. Underneath the care coordinator note is the clinician summary with more detailed information about the patient's risk factors and responses to screening questions. At the end of the clinician summary, you will find risk-based clinical follow-up suggestions that include current USPSTF guidelines. This information will be updated as new evidence and recommendations come in. The patient is overdue for a mammogram and does not have a future appointment scheduled with Dr. Bensching. In this case, Dr. Bensching decides to order a mammogram and sends a request to Abby to ask the patient to schedule an appointment and provide information about how they can schedule a mammogram. She then makes a sticky note as a reminder for the next patient visit. Dr. Bensching can also choose to add increased risk of breast cancer to the patient's problem list by clicking the outside records reconciliation option. This is automatically added by MammoScreen for patients at increased risk, but it is up to the clinician to add it to the problem list. Once the diagnosis is added, future clinicians can hover over the diagnosis to see the clinician summary in the overview section. At the patient visit, Dr. Bensching can verify the family history with the patient, update the mammography health maintenance modifier, and determine if a referral for genetic counseling is appropriate. This concludes the MammoScreen demo. Thank you so much for watching. Please don't hesitate to reach out to me, Dr. Bensching, or Karen Eden with any questions, concerns, or feedback. And thank you for participating in our study.
Thanks, Lindsay. And Lindsay's AI voice. The other thing the clinicians requested was some very simple risk-based clinical follow-up messaging. And we ended up bucketing it into 6 areas: average risk, younger age and older age, average risk due to family history risk scores. Those folks, of course, would be considered referrals for genetic counseling. Above average risk due to other reasons, which and above average risk due to known BRCA 1 and 2 mutations versus previously treated cancer. Part of one of the clinical follow-up messaging issues is for folks who are high risk, women who are high risk, should their screening for breast cancer change? And the answer is maybe and yes in some cases. And so that the next slide actually goes into detail about the recommended action in these 6 situations. So for example, if someone had a previously history of breast or ovarian cancer, we don't actually give a clear specific answer because that's such a large group with varied recommendations, but say surveillance should be individualized. Versus the person who has family history risk, we discuss genetic counseling, as well as recommendation for how to mitigate risk. Next slide. And I think it's Ben's turn.
Yes, thank you, Katie. So I'm Ben Orwoll. I'm one of the Peds critical care faculty and also clinician informaticist here at DMICE. I'm going to talk a little bit about our EHR integration and some of the things that we've done and some of the things that we've learned. So to support all these assessments and clinical workflows that you've heard about so far, we had to do a lot of work to integrate MammoScreen with the EHR that we all know and love so well. So to do this, we focused on information and data exchange standard called FHIR. And many of you are probably familiar with it, but it's short for Fast Healthcare Interoperability Resources. And it's been in development for about a decade, but is still in active development. It takes health data and packages it into resources, which are these discrete chunks of information, such as patients' observations like labs or vitals, medications, and many other data types that you might imagine. The format is really web friendly, and importantly, computers use a standardized application programming interface, or API, and security mechanisms to interact with each other using FHIR. Next slide. What makes FHIR special? Why would we like to use it? Well, the API is the key. The fact that there's a standard, open, and computable way to interact with systems like EHRs makes a lot of things possible. And big tech companies use these types of data interfaces all the time to allow users and companies to interact with their data. But beyond that, everyone is using FHIR because the government is starting to require it. You have probably heard of the Cures Act and information blocking. FHIR APIs are a part of these regulations and are a part of upcoming regulations around payment and coverage information exchange, among others. And it helps that FHIR is open source and free to use. Next slide. But perhaps the most important thing is that FHIR aims to make healthcare data and applications interoperable. And that means that using FHIR, we hope to be able to build things that can be used across multiple health systems with minimal additional work. ARC funded us in part based on the premise that we might be able to make MammoScreen something that could be used all over. First, though, we tried to make it work at OHSU. Next slide. And so here you can see each of the actors in this little play, and I'm going to try to demonstrate how we leveraged FHIR. Next slide, to help data flow back and forth between them. So first, we invite the patient to try out MammoScreen. Next, through a message from the EHR through their patient portal, sent via bulk communications from the EHR's population health tools. The patient then launches the application via OAuth-based smart launch. Next slide. This then allows the patient data to flow into MammoScreen from the EHR, sending identifying information, demographic data, medical and family history. These help to pre-populate some of the answers to the MammoScreen risk assessment. Next slide. The patient then completes the survey, and upon finishing, next slide, the resulting report, as well as pertinent conditions, are given to the patient and simultaneously written back into the medical record via a smart backend service API call. Next slide. Additionally, we send several messages back to the clinical team that you've seen already via a proprietary API. And this was an unfortunate departure from our FHIR-only approach that was a result of one of several limitations that we ran into that I will discuss. But it was especially important to allow notification of the triage nurse pool, like we've talked about, and if there were urgent new symptoms requiring attention. The story's not over, though. Next slide. So now that the data are in the EHR, the clinical team can review them directly there. But we also built a provider-facing smart launch that can be used by providers to bring up details about the patient's MammoScreen survey displayed within the application itself. Next slide. And the result of all of this, we hope, is a standard workflow that supports both individualized risk assessment and shared decision-making. Next slide. So we got a lot of what we wanted. We created a system that allowed for bulk invitations, population of patient health data into the tool from the EHR, writing of results back to the EHR for record keeping and clinician visibility, and all with a workflow that involves minimal human touch and could potentially scale much more easily than our old system. Next slide. However, next slide. Of course, there were issues. There were real limitations in the functionality, even of the limited set of write-enabled FHIR resources that our EHR supports. Conditions written back to the EHR were left in a state of limbo, as demonstrated, until manually reconciled into the chart by a clinician, which may or may not happen. Document reference resources, which are the notes that we write back, were limited to plain text, even though our EHR is heavily web-enabled. Another major limitation is that encounters cannot currently be created via FHIR. Every other piece of clinical data written into the system must have an associated encounter. And this left us forced to use a workflow that creates an encounter when each patient is invited to use the tool. It works, but it currently limits our ability to open up this tool on a completely public, invitation-free basis. So as I mentioned, there's currently no FHIR-based method of sending messages in our EHR. And lastly, we ran into a number of interesting policy and governance questions, many of which are more general in scope than just for our application, around how to handle data written into the system by FHIR and how service level FHIR applications should be allowed or not to interact with private or sensitive patient accounts within the system. But these things aside, next slide. I want to describe some of our early results, which are very encouraging. And we've got this application in production and have done 5 pilot waves, each with 25 to 70 patients. We have had so far an impressive 36% response rate, with 93% of those who have accessed the tool completing it. Next slide. And among those patients who did complete it, 12% have reported breast symptoms, 38% have reported information that was not seen when we queried the EHR via FHIR, and another 2% reported discordant information, that is, that the data pulled from the EHR seemed to be incorrect in some way. Next slide. Of course, we fixed a few bugs along the way as well. What are pilots for anyway? Next slide. So lastly here, I want to describe some of our upcoming plans. We're continuing to roll out to additional patients, and hopefully we'll be rolling out to even larger cohorts in our stepped approach. Later on, we have a series of interviews with providers and patients that are working to help us understand their experiences with the tool. And we'll also be continuing to review charts to understand how MammoScreen compares with manually extracted EHR data for risk assessment. And then eventually, we hope to make this tool more widely available to other sites and organizations. Next slide. So it's been a great pleasure presenting to all of you. And I want to thank, of course, all of our team, as well as ARC and DMICE and Mongoose Projects, which is where our developer has his company. And we want to open up, next slide, to any questions that the audience may have. Thank you.
Thanks, Ben. I will go ahead and ask a question. The comments on experience with FHIR is really interesting, and actually I think important because as many of us know, FHIR is being kind of touted as the do-all for be-all and do-all for interoperability. So it sounds like there were some kind of technical shortcomings with FHIR. Maybe you could just elaborate those a little bit more on what might need to be fixed or improved, and maybe not so much in FHIR, but maybe in how it's implemented in Epic. And,
Sure.
and then there's the larger issue of the policy questions, which actually no technology will solve.
Yeah.
And then maybe a second question might be is how would you, what would your recommendations be on sort of reconciling some of those policy issues?
Yeah, I think this is great questions. And it's definitely a challenging situation. You know, medical data the integrity of those data are really important. We want to make sure that as we sort of are innovative and are expanding the ways in which the medical record systems can interact with other systems like MammoScreen, that we don't compromise sort of the functionality of the core systems that we use to take care of patients. So I think it's reasonable that Epic and other organizations have been taking a cautious approach and a stepwise approach to implementing some of these new standards and the amount of integration that they are allowing with FHIR. I think that certainly the ability to read data has been really improving rapidly over time, and Epic has been a leader, honestly, compared with other EHRs as far as the support for different types of medical data that they allow us to extract via FHIR. I think, honestly, some of the technical challenges that we run into are that we as providers and as a system don't do that awesome of a job putting data into discrete places within the medical record. A lot of what exists in the medical record when it comes to the types of information we're interested in for risk assessments like this is sort of prose or scattered around. The clinicians in the audience, I'm sure know, if you want to find the pieces of data that you need to make a risk assessment for a patient, you might have to search through the chart for 5 or 10 or 15 minutes to make sure that you've seen it all. You might have to go to different organizations to find all those pieces of data. And so these are limitations that we haven't been able to fully overcome. I also think there's an element of the write back part of it that, honestly, Epic hasn't been required, and no one else has been required to support write back technology via FHIR, despite the fact that the standard itself is bidirectional. And so I think Epic has definitely incorporated some writing and will allow data to be written in. I think they're just they're taking it slow, and probably as we continue to advocate with regulatory bodies like the Office of the National Coordinator and CMS and other groups, we may be able to nudge that a little bit further. So I think there's progress, honestly, every year, every 6 months, we're seeing improvements and expansion of the amount of support that there are for some of these things. And our governance processes are really, I think, struggling to keep up. But to me, it's really all about, well, if I'm a provider, right, and I want to write data into the record system, I need to provide my credentials to authenticate myself and to show that I have the right to do that. FHIR allows you to do that just in the same way that you do when you log into Epic and write notes and sign orders. You can use the same credentials and the same login process. So I don't see those things as being very different, but still it's scary to cede a little bit of control outside your electronic record system. And so we're keeping work on that at OHSU. I think it's going to be a process. I don't want to take up too much time answering the question, so I'll stop there.
And we have a question in chat, and we also have Nicole Weiskopf has got her hand up. So I'll start with a question in chat. It looks like Katie has already responded.
Sorry, I'm getting.
Go ahead.
Yeah, so essentially, the clinician report has the information of the last mammogram, as well as the information needed to consider whether they would follow usual screening or not. So it doesn't give like won't give an official Joan Smith needs a mammogram July 30th next year, but the information to make that decision is there. Collated in one place, which doesn't happen now. Does that answer the question?
And then Nicole, you had a question?
Yeah. First, I just wanted to say this is a really fantastic project and presentation, and I really enjoyed all of this. My question is less about the technology and I guess more about decision tools in general. How do you keep them up to date? Either as, the treatments change or our knowledge about the cancer itself changes and how it progresses. How do you maintain the tools?
So that is an excellent question. We, as you saw, Dr. Nelson presented the evidence, and the whole tool is based on evidence. As the evidence changes, we do have to update the tool, which brings in a question of if a grant paid for the creation of the tool, ultimately you need to maintain the tool, and so at some point you'll have to figure out a maintenance strategy, and that we are including some maintenance kinds of questions with our post interviews, because it's not as easy as you might guess. But we do have built in a plan to work with Heidi about updating as evidence changes.
Cool, thank you.
It's like Stephen has a question, maybe.
Could I just add one comment there to that update? We've already tweaked it over the years, so we have the advantage of being the development team and the implementation team. But if it takes off beyond us, that is an issue. There'll probably be versions that have to be updated every now and then and distributed.
And I'll just tag on to that also, Heidi, in that I think one of the big potential benefits of having this type of application is that you can try to centralize the the knowledge expertise for some of these clinical guidelines such that people from all over are referencing the same knowledge center so that there's only one place where hopefully you have to update the guideline, the guideline or the risk assessment, rather than everyone rolling out a new version and then everyone across the country has to like update their logic in their own system.
My question was sort of building on Nicole's about maintenance. So that's maintenance about the clinical content, but what about the software itself? Like what happens when there's a new Epic version that supports a different subset of FHIR, or ITD changes the security policy and now whatever you were using you can't use anymore? What's the experience been with like the sort of practical implementation part, and how do you see that expanding to other similar tools at OHSU?
It's a great question. I think briefly, I'll just say FHIR has done some significant work as a standard on the maturity level management for the versioning. And so there are maturity levels, including in the most recent version, they've finally reached what they call a normative maturity level for some of the key resources. And so to that extent, if you're using the normative resources, you can have a good level of confidence that they're not going to have breaking changes for you as versions upgrade. However, not certainly far from all the resources are normative, so it's an evolution. I think anyone who's using innovative software products like this has to be ready to make updates to the software fairly regularly. And so it's a great point that, anytime you implement something like this, you have to have an ongoing plan for how are you going to support and fund the development and maintenance of the software. And it's tough because a lot of these types of applications don't have, built-in revenue generation streams.
Yeah, I know that's been an issue with other decision aid things in the past where the grant runs out and now there's not money to manage it. Does OHSU have any institutional plan for how, I imagine these things could proliferate over time and end up plugged into Epic in all kinds of ways. Has OHSU been having discussions sort of administratively about how to ensure that sustainability?
There's sort of a governance task force for some of this stuff that's in work. Final decisions haven't been made, but actually, interestingly, there's both the software itself and maintaining it and hosting it and that sort of thing, and then also Epic, of course, in their infinite wisdom, charges money to use these APIs, and so OHSU has been working also to try to figure out how are we going to support the actual kind of costs associated with the licensing of the APIs, cost sharing between applications, et cetera. And so that's all in ongoing discussions as we try to manage this.
And I can say, when we started this work a few years ago, there was pretty broad interest in the tool. I mean, every group that we presented to, both inside OHSU and outside OHSU, was really quite interested and wanted the tool, primarily for the ability to better identify patients at risk. So I think that ultimately OHSU probably will need to strategically think about supporting tools like this. And I think those discussions have already started. Nicole?
Sorry, I have another question. So I was really interested in the results that you presented on the differences between what the patient self-reported and what was already in the chart, either in terms of data that were not in the chart at all or that actively disagreed, which is something that I'm very interested in general. But I was wondering what kind of response, if there was any response from the providers you heard. What was their reaction to data that disagreed with what, you know, other people had already put in the chart or something like that?
The main, the first concern was, oh my gosh, this is going to create a lot of messaging back and forth about what, and especially if there's an anxious patient who wants their record corrected immediately. So we included some information on that. What else did the clinicians say? Let me think. I mean, we have encouraged waiting till an appointment and having a discussion in real time about it, and putting a flag in for us to remember in our sticky notes as the way to manage it, as opposed to getting into back and forth my chart messages or having a phone call. So setting expectations for how quickly it could be adjusted, depending, obviously, if someone has a new high risk issue and wants to get in, et cetera, that would happen more quickly. We'll have to see as it happens more. I actually am as worried about the unsure answers, creating taking time to figure out with low impact on change in care. But that happens all the time in practice, right? Where the patients aren't sure of the age of their aunt when they had breast cancer, for example.
There are also a few situations where there's been discordant data or what seemed like discordant data when it was really limitations on technology, like coding systems, for example. Like, we don't have a really good specific coding system that can say history of chest radiation in Epic. And so sometimes that can get a little non-specific. Like, if you have any kind of history of radiation, it might pull you in and suggest that that's part of your medical history, even if it's not, which then the patient sort of say, well, I actually didn't. And, you know, so then it can be a little bit of that kind of stuff that has led us to do a little bit of debugging in our application as well.
So I would add that our clinicians have experience with EHR data driving recommendations through the HM functions, specifically for colon cancer and vaccinations, et cetera. So we're used to providing feedback when it doesn't work quite well, and seeking clarity. So it's not like something completely new to us.
Thank you.
I want to be mindful of everybody's time. It looks like we're at 12:35. The whole team is available to answer questions. Feel free to email any of us if you've got questions. We're happy to troubleshoot and respond to your questions. If you can think of, there's groups that you think this presentation might be really helpful to go forward with to help move things along, that would be helpful too. Thanks, everybody.
Thank you.
Thank you.
Thanks. Bye-bye.